Features of CTG we are going to look at in detail, and how to classify as well. So now let's look at the features. Okay, so we have determined risk, and we have seen what all was high risk for and required to start the CTG, right? So all those things that we have spoken earlier, oligohydramnios, then FGR, SGA, all those factors are putting the mom and the baby at a high risk. Now, that is your determined doctor C provider. Now, the C is standing for contractions. Okay, so the contractions, what you need to look at is checked for by your tocodynamometer, right? And we said how many contractions are normal, as we have seen before. Okay, as we have seen before on your CTG, if it is more than 5 contractions, or if each contraction lasting more than 2 minutes is an abnormality. Okay, you don't want that, right? So that is something you are going to monitor. Now, what is BR? Baseline, right? Okay, baseline rate. Are you guys here? Dr. Pallavi?
Yes, ma'am.
Now, the baseline rate, how is it calculated? It is the mean FHR over 10 minutes, excluding any accelerations, decelerations. And in a post-term pregnancy, you need to have a lower baseline, and for preterms, usually they will have higher, because the nervous system gets more and more developed. Okay, by that we mean that the parasympathetics develop and the heart slows down. Preterms have a higher baseline, post-terms have a lower one. Now, baseline can herald an increase in baseline can herald some infection, hypoxia, and 200 209 is amber here. Okay, amber here. All right, so now we are looking at a variable which is called as contractions, which we have discussed already. Then we are looking at baseline variability, and we have features put as white, amber, and red, okay, for us. Now, a good baseline, which is a stable baseline, which is between 110 to 160. Now, why have I written some things in pink? Can someone tell me? So, I'm preparing for a long time. I put something in bracket here, but there are some things in pink. I don't want you to get confused about that. Okay, does anyone know? Dr. Ifat, since you had some confusion about CTG, can you know? Tell me about it. Dr. M, Dr. Parveen, Dr. Nazia. Okay, ma'am. Okay, fine. Mm-hmm. Mm-hmm. All right. Okay. See. Now the ones in pink I have written here, they belong to the old classification of the CTG. All right. So there are some questions which linger around in some Q banks and some of the books also, and at times. Even in the exams, they are asking questions which are relating to, like for example, they will give you somebody where fetal blood sampling has been done, or they might use the word reassuring, non-reassuring, abnormal. Okay, so I used to remember it as RNA, because our time CTG was like that, and then it changed to white, amber, and red. Okay, so remember that it was reassuring, non-reassuring, abnormal before, and now it is this white, amber, red, which I have put on top. And whatever I have written here are the changes which have come about. Okay, so what is there in your table without the pink marking? Pink marking is old. This is new. Okay, so this is what we follow currently. You don't need to worry so much about this. Is for given for reference. Okay, now remember that baseline FHR, which is FHR over 10 minutes interval duration. Okay. If it is remaining between 110 160, it is normal. If it remains 100 to 109 is considered amber, but it drops less than 100 is considered red. Okay, now tachycardia doesn't have amber anymore. It used to in the past, but it doesn't have amber anymore. It directly becomes red. Meaning anything more than 160 is becoming abnormal here or red as per the new thing. Is that clear? Okay. Previously it was between 160 180 prior to 2022, and more than 180 used to be put as an abnormal feature. However, we don't have techie in amber anymore. We don't have techie in amber anymore. We directly go to red when techie is there. But if it drops slightly, then it is falling here. However, you need to remember one thing about this. Okay? That even though this is amber, but if you are having this, okay, all right, but variability is, say, low, or you are having decelerations alongside this. Okay, that becomes something which is concerning for us. Okay, we'll see how that works, for example. Now let's look at the next feature, which is the variability. What is the meaning of variability? Variability is actually seen in a 1 centimeter graph of the CTG. Let's take a look at that. Let's take a example CTG now. Okay, this is a poor one. Okay, now the rate of this paper, as per NICE, we should keep it 1 centimeter per minute. That means each centimeter is counting 1 minute. Okay, now if you can see in this particular trace, for example, if you look here, the heart rate, it doesn't go like a smooth sailing thing, right? It goes up and down, up and down, up and down. So when I'm saying baseline here, my baseline here would be somewhere, this is say 210, right? This is 190, 150. So I'm saying my baseline over a period of 10 minutes. I take a 10-minute segment and I see what is on an average. I put a ruler there. I'll see what is coming in a maximum time zone. So I will see it's 150 here. So this is 120 and this is 150. Okay, that's my reading. Now, what is variability? In a 1 minute segment, say I'm taking from this point to this point onwards, I have to see the lowest and the highest here in that 1 minute. And that's my variability. Is that clear? It is not from this beat to this beat or this beat to this beat. In this 1 minute segment, how much variation am I having between the lowest and the highest? Is that clear? Guys, this is very important. Okay? Dr. Ifat, very good. Okay. Now, we exclude accelerations and decelerations while measuring baseline rate and while measuring variability. That also is obvious, should be obvious, but I'm mentioning here any which ways, because if within a deceleration I'm counting, my variability here will be, if you look at this 1 centimeter, it will be around say 10, right? So it's not 10. My variability is here. I'm not counting within accelerations, within deceleration. I'm counting in a base. Okay. So I take a 1 minute segment, I count the lowest and the highest within that, and that's my variability. Now, I look at the next feature, which is decelerations and accelerations. What are accelerations and decelerations? Accelerations and decelerations are either up and down. Up is acceleration, down is decelerations. For 15 beats overall, which should be minimum for a 15-second duration. Okay, so if you can see here, this is nightly dipping down but for less than a minute or so. Okay, and it's coming back up to my baseline, and that's why I'm saying this is a deceleration. Is that clear, everybody? Clear, guys? Come on.
Yes, ma'am.
Yeah. What about the rest? Yeah. Okay. So now let's look at don't see that particular chart. Okay, it's not that great, but let's go back to our table here. Okay, so what we see here is that normal variability. is between 5 to 25 any which ways. Anything which is more than 25, very concerning for us, even if it is for 10 minutes. Previously, it used to be for 15 to 25 minutes, but they've reduced that duration. Remember that? Less than 5 beats per minute for anywhere between a half an hour to 50 minutes. Okay, it's still in amber, but we wait for some more time if there are no other features. And if she crosses over and she reaches here, and now for more than 50 minutes, now she's pathological. Variability or less variability for a long period of time is pathological. Can someone tell me a trick to remember how less variability is for a less period of time? I mean, it's acceptable over a long period of time. Do you know the reason why? Reason why is reduced variability spells are common when the baby is sleeping. Okay. So we are saying maybe the baby is taking a nap for 50 minutes. But when it crosses over to this 50-minute interval, now we are worried. Here we are concerned because it's been half an hour that this baby is not waking up. Okay. But then the baby didn't wake up for 50 minutes and now variability is still low. I'm worried. But if the variability is too high, okay, that's neurologically not normal, which means that within 10 minutes, I'm worried with less than 10 minutes, then I'm still putting in amber, but it should go back down. Moment it is more than 10 minutes, I'm worried. Okay. Or sinusoidal. Does anybody know what sinusoidal is? I will show you a sinusoidal. What is sinusoidal? Sinusoidal is a distinct pattern in CTG. So because of that, it doesn't have its own separate like a definition and things like that. But let me show you what it is. Okay, can you see here on the screen? Yeah,
Yes, ma'am.
yeah. So what's seen here is this is a heartbeat which is going up and down, up and down, up and down, up and down. Seesaw, seesaw, seesaw. Seesaw is sinusoidal. Why is this problematic? It is pathological. There is no normal time that you see a sinusoidal pattern. It is because of the fetal hemorrhage. This means that the baby is bleeding. Vasa previa is where the baby is bleeding, or say a severe abruption from baby side bleeding is occurring, and this is the only times that you will get a sinusoidal pattern. Okay, you need to deliver immediately this baby. You don't have time for this baby. Okay, whereas let's see why the other patterns develop. Okay, so we've got accelerations. Are accelerations good or bad, Dr. Ifat? Dr. Ifat, are you there? No, I can't see the. No. Just give me one moment. Okay. Dr. Pallavi, since I cannot see the other participants here.
Yes, ma'am. It's good.
Good.
Acceleration.
Yes. Accelerations are reassuring. That means if you see acceleration, it's nothing to worry about. And if you see it with a reduced variability, okay, you're like this baby is doing fine. Baby is probably, taking a nap, but I have woken the baby up and there is an acceleration. That's always good. Decelerations, on the other hand, it depends on the timing of the deceleration. So you have to, and two things inside decelerations you need to remember. What are they? Dr. Nero. Two things inside decelerations. One is the timing, okay? Second is concerning characteristics and duration for which they are there, of course. Okay. So now if I look at um, decelerations in general, I have three different types of decelerations. Okay, so when I see this, okay, I told you what it is. It is more than 15 beats per minute, each lasting more than equal to 15 seconds. And exception is in reduced variability, they can be slightly shallow, but other than that, these are the features that you are supposed to look for. And let me show you so that you can remember it better. Now, one feature I said was the timing, right? So there are three different types of them. One is late. Late means late in relation to whom? The contraction. So if you can see in this particular feature, the contraction passes off. At the time that it is passing off, I am starting to get my here. Okay, this is coming at this particular point in time. So it is my contraction is already passed off, but my peak is after the contraction. Every single time my peak is after the contraction. I'm looking at it like this. Every single time contraction has come and gone, my peak is coming after. Look at the peak, okay? Don't see the start of it. See the peak of it after contractions every time. That is why this is late. Okay? Is that clear?
Yes, ma'am.
Yeah. Next is you have a early deceleration. Let's see. Early. Did I put early? I don't know. Early is actually basically gonna be exactly mirror images. Mirror images. Let me right now not able to find it. Okay. I'll put the common one for you. Hmm? Early deceleration is essentially whenever contraction is there. This is a uterine contraction, and you see this is increasing, going down. This is a mirror image of it. This starts peak of this, trough of this, peak of this, trough of this. Okay, got it? That is an early deceleration. What is the cause of this? Head compression. Okay, and then late deceleration was because of uteroplacental insufficiency. So we are kind of worried about that. Variable decelerations are coming usually because of cord compression. Now, cord compression doesn't really come and go with the contractions, right? Unlike uteroplacental insufficiency, unlike head compression, which are connected to your uterine contraction, but cord compressions can come and go and a little bit more random, and because of that, okay, the effect is also a bit random, and they can be anytime before a contraction, during a contraction, after a contraction. You're seeing them anytime. They don't have correlate with the contractions generally. So that is variable deceleration. Okay, Dr. Ifat. Is there something you want to go over? One second. Just a minute. Um, okay. Is the screen visible? Screen is visible?
Yes, ma'am.
Ah, okay. All right. Let me just share this then. All right. One second. Mm-hmm. Seen now? Yeah. Okay. All right. Yes. And so far with CTG, any questions? This is very, very, very important part of it. Very important. Okay, for your exams. Extremely important. So please note that. Yeah, thank you, Dr. Effer. All right. So, as I told you how to calculate baseline, I also told you how to calculate variability. Hmm? Now, you need to understand that you can't have just one feature being assessed at any point, given point in time. Okay. Now, if there is absence of variability, it is highly concerning. Absence of variability, not reduction. Say it's a smooth, like up and down with just coming and going with the contractions. Some of the decelerations are coming and going with the contractions, but there is no up and down happening on the CTG trace at all. So absence of variability is extremely bad. That means the baby is not reacting to its external stimuli. Hmm? Neurologically depressed baby, you want to expedite birth. Sinusoidal, always expedite birth. Okay, baby is bleeding inside. Hmm. Now, intermittently reduced variability, I have told you because of baby sleeping, they can be considered okay. But if it crosses more than 50 minutes, then we are worried about it. Opioids also can reduce variability. But please do carefully review this, because if there are other abnormalities, for example, variability is gone, but there is tachycardia. Okay, variability reduced with tachycardia in the fetus. This is worrisome. Hmm? So if it's more than 160, reduced variability, you're still worried about the baby because it can indicate something like maternal sepsis. So that this is how you need to interpret in terms of CTG. Now, um, coming to decelerations, I have mentioned the same things to you. I needed to mention about concerning characteristics, and for that, I have this particular slide to you. When I mentioned the three different types of decelerations which is there, they are either important because of the timing with which they correlate to the contractions, or the other thing is you need to see concerning characteristics. Now, older guideline had 5 concerning characteristics. The new one has just 4 of them. They have removed this biphasic or W pattern. Okay, I put a cross on it. It's a bad looking cross, but I put a cross on it. And the earlier one had all of them 5, but any deceleration which is lasting for variable deceleration, which is lasting for 60 seconds, okay, or longer, any variable deceleration that does not come back to normal, meaning this is your baseline, it went down, it didn't come up, it remained there. Okay, any deceleration which is not having variability, can you see this up and down, is not happening here. So this is a reduced variability inside a deceleration. And no shouldering. Does somebody know what shouldering is? Shouldering is when deceleration, okay, comes, okay, and as it is climbing, it goes up here like a shoulder, and then it comes to baseline. Shouldering is normal, absence of it is not. Okay, so you can see here that overshoot is not happening, overcompensation is not happening. So that is these 4. Can someone repeat them for me, please? Dr. Nero. And Pallavi is also okay. Yeah. You answer every time.
Yes, no shoulder is a concerning features.
Mhm. All 4
Not
concerning features name quickly.
okay. This not to return to the baseline.
Hmm.
Then absence of variability during the deceleration
Hmm.
and deceleration more than
Hmm. More than not listening. Okay, 60 seconds.
60 seconds. Sorry, 60 seconds.
And absence of shouldering. W pattern was there in the older guidance. It's no longer there in the newer guidance. Okay, that is something which is removed now. So now that is the reason I have put these pink ones in the old guidance, slightly here for your reference. Please do not get confused. Okay, now when we say all this emphasis that we are putting in, we are just talking about concerning features in variable decelerations only. We are not talking about late decelerations. Right? Late deceleration in themselves are indicative of uteroplacental insufficiency, correct? So we are worried the moment we have late deceleration of any nature. Any nature, late deceleration, we are worried. Any nature, early deceleration, we are not worried because we know it's head compression. They are very rare and doesn't. Okay. So we are not worried about early. We are definitely worried about late, but variable, we are worried if there is, okay, there are concerning features and their timing we have to remember. Okay. Now there is a very easy trick to remember with the newer guidance. Previously, what they used to do is, if there are no concerning features also, but it was more than 90 minutes, it used to be put in amber. Now it has become much more simple. Variable having no concerning features is all white. Doesn't matter how long they are there. Doesn't matter. Okay, if there are no concerning features in variable, do not worry, put it in white. If there are concerning features in variable, you need to see half and half rule. Okay, this is how I remember. Okay, half and half means more than half an hour, either more than half an hour variable with concerning features, or more than half the times. Means what? Repetitive. Repetitive is a new term used here. Repetitive means if it is associated with more than half the contractions, then okay, or it is there more than half hour. So it is either this or this, because if you have this plus this, meaning half plus half more than half the contractions, but more than half hour, then it is becoming red. You can see here, it's becoming red here. Got it? Now, okay. So either both half, but more than half the times is becoming red. Either one is put in amber. Remember, they need to be concerning. If repetitive late less than half an hour is remaining in amber, but once they cross to more than half an hour, late becoming red. Late more than half an hour becoming red. Okay. Now the third feature which was there, which is very simple and remains the same in both guidances, is acute bradycardia. Okay? Single prolonged deceleration which is more than 3 minutes is always red, meaning it's just not coming up for more than 3 minutes. That means either the patient has had cord prolapse, had an abruption or rupture. Okay, can't be anything else. Okay, cord prolapse, abruption, rupture. These are the three reasons why you would have this acute bradycardia. You want to think about expediting if it's not coming up. Hmm? We'll see how what the guidance says about that. So everybody clear about decelerations, right? Variability we have seen. Variability, how to remember. If it's reduced, baby may be sleeping for some time. So you give baby half an hour. Is we consider normal half an hour nap. But baby sleeps for a bit longer. We are little bit worried. Longer than 50 minutes, we are definitely worried. Baby having more is definitely worrisome, and crossing to 10 minutes itself becomes bad for you. Okay, easy to remember, Dr. Ifas. Hmm? Yeah, very good. Okay, now we've crossed the first stage of classifying them as per the categories, but we see when do they become normal, pathological versus suspicious. What is it? NSP, normal, suspicious, pathological. Okay, what do we call that? Hmm? Right, and let me just check if there is anything I need to mention which is important here. Not really covered this, covered. Okay, all right. All right, yeah, this one, as I've told you, it has been removed now, and okay, as I've told you earlier, I'm just exemplifying again here. Please remember that if decelerations are present with rise in baseline or some change in variability, like two features are there and it's becoming like it's still falling under suspicious, suppose, from a timeline point of view, but you have concerns about acidosis, please remember that it doesn't matter. You need to still review urgently. Okay. Alright. If decelerations are present for more than 30 minutes with a rise in baseline or reduced variability, urgent. If antenatal or intrapartum risks are present, okay, with decelerations and they are making you think something is wrong, then please again think about expediting births after excluding those events. Okay, accelerations, whenever they are present, they are a good news. Okay, they mean that the baby is doing well, and even with somebody who's having, say, reduced variability, it's fine. Okay, reduced, not absent, reduced. Now, In second stage of labor, this becomes much more challenging. Maternal pulse is checked every 5 minutes, right? Right? Just like FH, the fetal heart auscultation every 5 minutes, and alongside that, every time you were checking maternal pulse, correct? So similarly, and if any doubt, you want to either put scalp electrodes, but not practicable, or expedite birth. Oh, so one more feature which I have written in the table as well, but note that a rise in the baseline, okay, which we had seen earlier was falling in amber, right? Correct? A rise in the baseline, all right, would fall in amber before, isn't it? So, but in second stage, a rise in the baseline more than 20 is considered a pathological feature. Okay, it's a red feature. So, if you see that the fetus is getting hypoxic, please discourage pushing and stop oxytocin. This is one point you have to remember about rise in baseline. Great. Now, again, it is classification. Thankfully, these names have remained the same. Previously, it used to be called as RNA, right? Reassuring, non-reassuring, and abnormal, correct? RNA was white, amber, red, new one, correct? Now, however, the categorization of the CTG, the names have remained the same: normal, suspicious, pathological. Essentially, no amber or red feature is normal. Any one amber feature is suspicious. This much, if you remember, then the other two are simple. Okay, nothing means normal, and one amber. So more than one amber is pathological, or one or two reds is pathological. Okay, so very easy to understand, and this is the new nice guidance with respect to each one of them. I put them in a table so that it is very easy to remember and understand. Normal, continue the CTG, don't do anything, do hourly assessment. Clear? Yes. So suspicious, there are two things you need to remember. One is there can be concerning risk factors, like what high risk is the mother having, or versus no high risk, right? If there are no other risk factors, okay, no other risk factors, everything seems to be going okay, but there is one amber feature for whatsoever reason. You do a full assessment. It can be because there are some abnormalities that you pick up, which you can take conservative measures for. Okay? Meaning, you have found underlying reasons for it. There are four underlying reasons. Can someone name them? Four underlying reasons that you want to correct. Okay, never mind. We will, as we see the assessment, what is conservative management, etc., measures, etc. We'll see that. Okay, so you do a full risk assessment. You try to identify those underlying reasons why it has happened, and you are going to try and take conservative measures, and then your CTG might correct itself. Hmm? Acceleration being present here without concerning features in the mother, it's always good. Acidosis is unlikely. Now we come to category where we are worried about the mother for some reason and she's having amber feature. Now the thing is that because there is a determined risk factor in her, we still can do all this maternal sets of observations and full risk assessment. But if we do identify some reason, underlying reason for it, like for example dehydration, we can take corrective measures for it. But at the same time, we are considering fetal scalp stimulation or expediting birth, meaning depending on the risk level. For example, if this is previous scar, okay, and I have not found any dehydration, any other reason why she should have an abnormal amber feature in her at all. I am now worried that it could herald that there is a rupture going on. I might consider expediting birth. Okay, am I being very categorically clear here? Please. Okay, this is where mistakes will happen. People don't just read the CTG. Please correlate the CTG with what the task at hand is. Okay, what the question is saying. All right. Now, okay, is that clear? Chat box, please. I'm not seeing any answers. I'm gonna wait. What about the rest? Pallavi, Emma. Last one, yeah. See, if there are concerning risk factors in the mum whatsoever, okay, which is why you have put the C2G and you're worried that something is causing acidosis or some fetal abnormality may be there. Okay, if the variable deceleration with concerning characteristics is coming up in a woman with previous cesarean section in labor, okay, you're not going to say this is just a suspicious CTG. I'm going to wait and I'm going to do scalp stimulation and see, okay, or that I'm going to put her in lateral position and I'm going to check or mobilize her, move her and see. This is not what you will do. You might want to take her up now because this risk factor is what is coming into the picture. Now, if however I'm having a primary gravid patient who didn't have anything, no fever, no reason for me to think about anything, not having bleeding, no meconium, nothing. Now this lady is having one amber character, same CTG. I am going to say, okay, let me try some things. I will do fetal scalp stimulation. This is how I will assess what I need to do. Understood? Is that clear? Very good. What about Dr. Nazia, Niro, Emma? Emma? Okay, good. Now coming to pathological CTG. Pathological means a red feature or two amber features. No? That means something might have gone wrong. You want to rule out acute event, something like cord prolapse, abruption, rupture. Okay? If yes, definitely, meaning you're going to take very quick actions here. Very quick actions for pathological. Now, if none of these are there, you've checked for everything, doesn't seem likely. Now, I undertake sometimes conservative measures, okay? And if still pathological, then I would want to expedite birth. Please note that the previous guidance, okay, prior to 2022, at this point added fetal scalp stimulation and fetal blood sampling also. So before expediting birth, they were advocating blood sampling at this point of time. Got it? Okay. Now this is in red here mentioned. I will show you exactly how it went back then in the day. Now note, I had said that prolonged bradycardia more than 3 minutes was a problem, right? But what do you do at that point of time? You want to, now this is the one, right? So you rule out cord prolapse, rupture, or abruption, which is occurring very acutely, or other risk factors for fetal compromise, which may be there. There's a spelling error here. I will correct it. Now, if you do find any of these, okay, with a single prolonged deceleration, please, yes, deliver. Deliver. If you do not find, you start making preparations, start shifting the patient, start informing the theater, do everything. Go down to the theater, auscultate again, see if the FHR has recovered. You give up till 9 minutes to do so. Okay. If recovery within 9 minutes happens, okay, then you reassess the woman's need for urgent delivery and discuss with her. If doesn't recover at 9 minutes, please expedite and deliver. No matter cesarean, if she's fully dilated, then you can do some sort of instrument, maybe if you can apply it, but if not, then please do a cesarean section. Clear? So 3 minutes, start taking action. At 9 minutes, expedite birth. Okay? 3 minutes, start this thing, informing. Okay? 6 minutes shift. 9 minutes, cesarean. Okay? Now, this is prior to 2022. Don't need to know so much detail about it. It's the older version of it. The only difference I want to show you is when it is pathological, what happened here. So, if persisted, review and then consider interventions, digital scalp stimulation. If after this remaining pathological, you either had option between FBS or expediting birth. So, this is the one you need to look at. But this is older. Okay, we are following this one. Do you know why the change was made of removing FPS? Dr. Pallavi? Nero?
Yes, ma'am. No, ma'am, I don't know.
Okay, let me show you a excerpt from the NICE guidance, which is this is the latest guidance, right? 2023. So it's why the committee made this decision. Essentially, it said that because there was a lot of time delay in expediting birth, okay, because of the fetal blood sampling which was there, and versus just digital stimulation with CTG assessment alone, it does increase the chances of a cesarean section more, but reduced UPGARs they reduce when you're not using MPS. Okay, low UPGARs reduced when they stopped using FPS. But there is a trial which is undergoing, which would have concluded in 2024, and based on which they wanted to make further recommendations. As of now, they were not making. But I'm sorry to have to say that in exams you get questions about FBS values and what is the next thing to be done. Okay, you still get, there are centers in the UK where it is still done, local guidance are still available, and they are doing it. Okay, so the thing is that you need to know what is to be done. Okay, so I will just tell you very quickly what needs to be done for your exam purpose. Okay, now so prior to 2022, as I said, fetal scalp stimulation was pathological even after initial conservative measures. If you did scalp stimulation, she got an acceleration. The CTG trace went back to normal. Everything is hunky dory. You don't do anything further. But if persistently pathological, okay, persistently pathological, you either could do FBS or consider delivering. If you couldn't do FBS or you had other reasons why you thought that delivery is required. Now, if you're doing FBS, please follow this chart. If FBS was normal or borderline, you could continue the CTG and review. Okay, timing differs, I will tell you. If FBS was abnormal, so FBS is categorized into the value, depending on the value, it's categorized as normal, borderline, abnormal. Okay, normal, borderline, abnormal. Three things. If it's abnormal, you had to deliver. If it's normal or borderline, you could repeat it, okay, for a total time two. Okay, couldn't do it more than two times. If they told you in question, it has been done, then half an hour later it is repeated again. Now again it is showing borderline. You don't choose do in another half an hour. No, done, khatam. Okay, maximum. That's it. So now, if this is not CTG improves and doesn't become pathological, you don't repeat it. Obviously, you leave the woman alone. But this CTG is still persistently pathological. Okay, so here also CTG was pathological. You did something; it's still pathological. So you did FBS. The FBS is either normal or borderline, but the CTG remains the same. So now you're still worried, but there wasn't any acidosis. So you repeated FBS, okay, and if it is again normal or a borderline, you continued CTG. But if it is still pathological, you don't do another FBS. Twice you have done. Then, if it's again pathological, please deliver. Okay, please deliver. Hmm? If it's abnormal, again deliver. So that's the thing. If during this time, however, say here she was 8 centimeters and now she becomes like 10 and she fully dilates and delivers, that's well and good. Okay, or CTG could turn normal, all right, and then it would happen. Now, when do you repeat? It's very simple. This much you guys understood. This is very simple. The guideline, in fact, was very confusing. But if you look at this, this is how it is going to be. Okay. When do you repeat? For borderline, you repeated it in 30 minutes. For normal value, you repeated it in 60 minutes. Okay. Obsolete, Dr. Nazia, I just showed you evidence from nice statement. It's not, it's being practiced. It's also being asked in your questions, which is why I'm telling you how to categorize it and what to do in case they give you FBS values. Okay? Got it? Guys, come on, wake up.
Yes, ma'am.
Okay? Okay, if it's normal, FBS is repeated within
60 minutes.
Very good. Very good. Okay. So fetal blood sampling indications were pathological CTG, persisting. Contraindications we know, acute events. And overall picture indicates that expediting birth, unless your expediting birth is safer, is what you think. Okay. And in that case, obviously, if you're thinking some cord prolapse is there or rupture is there, please don't sit and do FBS, okay? So that's not. Or if you think the MTCT, mother to child transmission possibility or risk of bleeding disorders in the baby, please do not do FBS. Hmm? Caution needs to be paid to the fact that FBS can be reassuring in sepsis or significant meconium, okay? And always collect the samples in left lateral position and also do not ever do it after a prolonged deceleration. Okay, always, never after a prolonged deceleration, always in left lateral position. So you want to get the best result. You don't want to create false acidosis in the baby, okay, by causing compression of the IVC. All right. The values as promised, normal, borderline, abnormal, is pH values of 7.25 or above. Okay, so remember the middle values 7.21 to 7.24. So anything below this pH is acidotic, abnormal. Okay, anything above it is fine, it's normal. Okay, similarly to for the lactate, 4.2 to 4.8 is what I remember, and then anything more than that is acidotic, anything less is normal. Okay. Okay, so if I see these values, I will repeat in 30 for total samples of 2. And then if I see this, I'm going to deliver now. If I see this, I will say repeat in 60. Okay? Okay, guys? Okay, as promised, let's go to the underlying causes and conservative management. So there were 4 causes, like I told you, right? So it could be because of the mother's position, or it could be because of hypotension after an epidural, or general hypotension, or any signs of sepsis, or excessive contractions. So I'm trying to look for any of these reasons why my CTG is becoming amber or red. Essentially suspicious or pathological. So if I find any of them, I'm going to correct them. What do I do? I encourage mobilization, change to alternate position, avoid a supine position. Hypotension after epidural, I can start IV fluids. This is a question. Or and put the patient in left lateral position and call an anesthetist because she's developed hypotension after epidural. And if I see otherwise hypotension or signs of sepsis, I can start IV fluids. Okay, I do not start this without hypotension. Do not start IV fluids without hypotension being there. Excessive contractions, I will reduce or stop my oxytocin, and I can even give tocolysis question again. So 2 questions in the past here. itself. Okay, FBS, very important question. CTG categorization, very important. Even EMQs have come, okay, in that. So please pay, this is very important section. Okay. If suspicious or pathological CTG, always perform full risk assessment, full set of maternal observations. These are your conservative measures. So I just want to go back once and I want to re-emphasize what we saw in the first table that we had here. Okay, what we did here. So if suspicious, remember, I'm going to look for my risk factors first. I don't find any. Then I look for the cause, underlying cause. If I find position, dehydration, excessive contractions, I take corrective measures. I wait for my CTG to come back to normal. Similarly, I see here risk factors, but if they are very concerning for me, I might consider delivering. Please don't take the things very literally and get a wrong answer. It is not mechanical. Okay, many factors need to be considered when you're picking your answer. Okay, similarly it goes here without saying. Similar approach is there. First you rule out any accidents which are occurring, take conservative measures if they should be, and if despite corrective measures it's not happening, please deliver. Okay, as per the newer thing, please deliver. Okay, are you guys tired? Yes. Nausea. Okay, you guys want to discuss second stage and instrumental births maybe another time? We can finish the we can finish the come on guys, I'm the one who has been talking. Yeah. All right. Okay, let me see where we can stop. We'll just finish the CTG section, that is record keeping, which is my last slide on it. And to ensure accurate one, once one question has been asked on it, please note this, okay? So, this one is done, right, okay. So with CTG, please note that you do not offer facial oxygen or CTG alone, and it is given if only if maternal hypoxia is there. Do not give amnio infusion. Do not give IV fluids unless there is hypotension. Do not do fetal blood sampling as per the new thing. Okay, so you will not ever pick it, but if you are given a value, you should know what to do. Scalp stimulation is done if suspicious CTG, but if accelerations and CTG improvement, then please don't do anything. If no acceleration with fetal scalp stimulation, this is problematic. Okay, if you wake up the baby and the baby is not waking up, baby is not having an acceleration, not good. Okay, it's not good at all. Now, record keeping for CTG is to ensure accurate record keeping for the CTG, and you need to make sure that it is dated and timed correctly and the speed is right. This I have told you 1 centimeter per minute before as well. And you label them with everything, the date of birth, hospital number, NHS number, okay, all of these things. And how long do you keep it? This is the question. Okay. Your answer to that question in the scenario was indefinitely. So I'll tell you what they asked you is that there was neurological injury, brain injury sustained at the time of birth. Okay. So in this situation, the CTG is stored indefinitely, remember? And otherwise, if there is no, known abnormality in the child, okay, then you keep it for 25 years and if possible, store them electronically. However, if there is any a sort of like you delivered because of hypoxia and then there was HIE of any kind, please, indefinitely is the answer. Okay. Also, you need to keep traces on the CTG. This is not asked, but if somebody takes it for examination, it is they need to be returned back to the system. Okay, that's all about fetal monitoring, which I included within this, and I was going to come to second stage and also discuss about your assisted vaginal births within this section after diagnosing delays, etc. But I guess if you guys are tired, then we can do it another time. Okay. All right, so we'll finish second and your third stage because we have to do a bit of details of fetal skull. Okay, lots of questions come about the diameters and about presentations and about forceps and ventouse. And when should you do what? And I need full attention for this. Nausea, I would have to see.